Asthma is the most common chronic disease worldwide. More than 339 million people are living with asthma. Over 80% of asthma-related deaths occur in lower middle-income countries. Asthma is underdiagnosed and undertreated. It creates substantial burden to individuals and families and often restricts individuals' activities for a lifetime. Although asthma cannot be cured, appropriate management can control the disease and enable people to enjoy a good quality of life. If left untreated, there's a greater risk for long-term effects and severe complications. These long-term effects include airways remodeling, hospitalization, asthma attack, and respiratory failure. Despite affecting billions of people, there are various myths and misconceptions concerning asthma that prevent asthma patients from enjoying optimal benefit from the major advances in the management of this condition. In this series, we provide a clinically focused overview of asthma, emerging therapies, controversies, and uncertainties in asthma management from the experts.
Hello, I'm Sujit Rajan, a consultant pulmonologist at Bombay Hospital Institute of Medical Sciences and Bhatia Hospital in Mumbai. And I welcome everybody to episode 6 of Healthcare Superstars. As you're aware, we have completed 2 series now within the respiratory segments, each with 2 episodes. The first one being on IPF and other ILDs, and the other on COPD. The third series is on asthma, and we have already done 1 episode, which you have hopefully tuned into. In episode 6, we move into another important concern area within respiratory medicine, which is intricacies and case scenarios in asthma, which are important and possibly very useful to you in clinical practice. And in today's episode, we shall be addressing interesting asthma mimics, differentiating asthma from COPD in clinical practice, and the ever important issue of when to use and when not to use nebulized therapy. Before I move forward with inviting our speakers, I would first like to thank our collaborators. These are the Sri Lankan College of Pulmonology, the Myanmar Thoracic Society, AAA and AOSR from Algeria, APPM and Asthmapath from Morocco, the Iranian Society of Pulmonology, SDNCT and Pneumonaut from the Dominican Republic, the Panama Pneumology Association, and the Yemeni Association for Respiratory Care. Coming to our first guest today, Dr. Alan Kaplan. Alan is a board member of the International Primary Care Respiratory Group, the IPCRG, and a member of the Health Quality Ontario Asthma Standards Group. Alan has been a past chair of CPFM Respiratory Medicine CFPC and has over 480 presentations at different international and national conferences. Alan has acted as principal investigator in almost 50 clinical trials and is the international editor currently for Nature's Primary Care Respiratory Journal and has over 145 peer-reviewed publications and 104 abstracts. So we have a respiratory physician in primary care, literally. Welcome, Alan, to today's meeting. I would also like to welcome Dr. Jaime Correia de Souza from Portugal. Jaime is the past president of the International Primary Care Respiratory Group, is also a member of the advisory board of the Portuguese National Respiratory Disease Program, is part editor of the Education Society of the Primary Care Respiratory Journal, and a past member of the research subcommittee of the International Primary Care Respiratory Group. Jaime has over 84 peer-reviewed publications. Between the two of them, I can tell you that we have the best of respiratory medicine in primary care practice that we can offer you today. Okay, so over to you, Jaime. Please go ahead with your case.
Here we have a 42-year-old woman, Julie. Julie has an appointment. She complains of shortness of breath on exertion. She smokes and has occasional wheezes. What could be her diagnosis? Looking at her clinical records, the doctor notices previous visits for acute bronchitis. and they were treated very often with antibiotics. When specifically asked, Julie mentions frequent previous visits for acute bronchitis since she was 6 years old, worse since she started smoking at age 22. She presently smokes half a pack a day for 20 years, and she also grew up in a family of smokers, which means she has been exposed to smoke for a long period of her life. Julie has been worsening the last 3 months. She complains of shortness of breath when walking upstairs. She has wheezing at night and productive cough, and worse in the morning. Julie also noticed it in the colder weather. Also, we can do the 30-second COPD test, and that we can ask the patient and ask ourselves about this, and the patient can help us to diagnose. Do you smoke currently, or have you smoked cigarettes in the past? Do you cough regularly, which has certain characteristics we'll talk about later? And in asthma, the most important key point is that the obstruction is reversible, except that in latest stages of asthma it might not be. So it can also be confused with COPD in later stages in severe asthma. So here we look at Julie's spirometry results. This is the flow volume curve, and you have the characteristic notch that you see when there is obstruction. What is the characteristic of this curve here is that the curve before bronchodilator and after bronchodilator are almost similar. So it means there wasn't the test didn't show any reversibility. And now we can look at some Julie's spirometry results. The results, we can see that the predicted FVC was 4.37 liters. The measured was 4.65, so you had 106% of the predicted. The FEV1 was lower than 80%, 79%. And when you look at the right side of the slide, there was only 70% increase after the bronchodilator. And the ratio was also under 70%, and after the bronchodilator, it was still under 70%. So, Alan, we'd like to show the diagnostic flow diagram for obstruction.
Yeah, so build the slide, please, James. So this is a diagnostic algorithm we've created for spirometry. And Jamie has just gone through this with you in the case before, but if you sort of review that, the first step we look at is looking at the ratio. And if the ratio is low, then you have obstructive airway disease. So when you look at that, the next step after that is the FVC low, and then you're looking to see whether or not there's restriction. The funny thing about FVC is it's normal above 80% rather than 100%. So if the FVC is less than 80%, then there is a degree of restriction. So if there is both obstruction, the ratio is low, and restriction, the FVC is low, then you have a combined deficit of obstruction and restriction. At this point, it can be quite complicated. So very simply, you give a bit of a SAB and a bronchodilator, and you see if it reverses or not. And if it does reverse, then you have a likely diagnosis of having an obstructive airway disease like asthma. And if it doesn't reverse, then you need to investigate further why this person has restrictive airway disease, and you need things like full pulmonary function tests and CT scans, etc. So restrictive airway disease is not really what we're talking about here today. Many things cause restriction. If you have a chest wall problem, a neuromuscular problem can cause that, but airway obstruction is what we're talking about here. So if the ratio is low, less than 70%, the FVC is normal, then you have pure obstruction. If you have pure obstruction, then the question is, does it reverse or not? If it reverses, then you're considering asthma. If it doesn't reverse, you're considering COPD. And I say considering because, of course, as James already said, if you have very fixed obstruction from bad asthma, it may not reverse anymore. And we know that some patients with COPD will have some degree of reversibility. So it's all going to be a matter of how much reversibility and how much obstruction in a clinical setting that's going to help you decide the situation. So going back to Julie's spirometry that we saw earlier, her ratio was 64%, her FVC was normal, and therefore, with a lack of reversibility, her COPD looks like her spirometry looks like it's got COPD.
So these are the key points for Julie.
Yeah.
We consider that she might have COPD. So we know that smoking cessation can prevent further long-term lung damage or slow the rate of decline of lung function. And also that if one bronchodilator fails, We have to ensure patient is compliant and able to use prescribed delivery system properly. And we also need to have to use stepwise approach to the treatment plan. And we have to do this in a circle. And this is a review, adjust, assess circle, and it's very similar to the one we have been doing for asthma for quite some time. And now it's also an approach that we are using for COPD. In every opportunity, in every encounter, we have to review and assess and adjust in a cycle, so that we are sure that we are delivering the best care.
Julie had a childhood onset of symptoms, and she has lost a lot of lung function. And she gives this history of attacks of bronchitis, which is very common in histories that we get. So do you think the primary care physician should straight go to one bronchodilator, and if it fails, a second? Or wouldn't you consider a course of inhaled steroid trial, because in the hope of regaining lost lung function, considering she is young and we have not given her the opportunity to really improve?
If we look at this spirometry,
yes,
it looks quite a lot as a COPD. As the case progresses, we'll probably question that. Assuming it's COPD, obviously the initial start could be a bronchodilator. Except that we have this, as you mentioned, we have a quite clear childhood set of symptoms that have been occurring for repeatedly, and we should consider, could it be that she has had, since her childhood, she has had asthma that was not diagnosed, and when she started smoking, it got worse, and it became either COPD or a mixed combination of asthma COPD.
Just to review back on Julie's spirometry, that she does not have restriction based on a normal FVC above 80%. Her FEV1 is 79%, so she has mild obstruction, and it does not reverse. So this appears to be a condition of COPD based on the spirometry. But if, and Jaime, to you,
what if these were Julie's spirometry results? Then we look at a complete different scenario, because here we see that the FEV1 increased from 2.98 liters to 3.50 liters. So that means an increase in 70.5% and over 200 milliliters. And so it might look that after all, and also the FEV1 FVC ratio increased from 64% to 75%. So after all, when you look at this, it looks like a different scenario. It doesn't look like COPD anymore, but it looks more like asthma. What do you think, Alan?
Well, very important what Jaime says. So this is a situation that shows that there actually is reversibility, and now her ratio is above 70%. So now you can categorically say that she does not have COPD. This makes all the difference in the world. Again, we've shown you two different situations of what the spirometry could look like. This is one where there is reversibility. The last time there wasn't. And obviously they're not both the same person, although just to make things difficult, you can actually have differences in different results in different days. And that's why most international guidelines recommend repeating spirometry in people with COPD before you label them, to make sure that in fact there's no reversibility over time.
Yes, let's look at the goals for effective management of asthma. And we have here a slide from GINA. GINA is a global initiative for asthma. And here they are: achieve and maintain control of the symptoms. We need also to prevent asthma exacerbations, maintain pulmonary function as close to normal levels as possible, so that the patient with asthma can maintain a normal activity level, including exercise. There's no excuse for an asthma patient not to exercise, because we can always control, or most of the times control, their asthma so that they can exercise. Actually, there's a lot of high-performance athletes who have asthma, and they have still achieved Olympic medals. We also have to avoid adverse effects from asthma medications, which means treating with the minimum efficient dose. So if we have gone up on the steps of asthma treatment, and we have able to manage and control symptoms, we have to try to go down and see if it's still manage this asthma properly so that we keep the lower level of medicines that control the disease. We also have to prevent development of irreversible airflow limitation, and this is when we have severe asthma, this has to be treated in a different way by a multidisciplinary secondary and tertiary team, which can look at asthma and give appropriate medicines that are now available, and it's an opportunity for patients in many countries to have their asthma managed properly, not develop to an irreversible airflow. And we also have to prevent asthma mortality. In the developing countries, there's still a lot of asthma mortality. In the higher income countries, asthma mortality is residual, but still there is asthma deaths which are mostly avoidable. And this is one of key issue because very often it's people that navigate badly the system. They are jumping from doctor to doctor, doing doctor shopping and going from emergency service to different practitioners, and they get lost in the system, and they often do not do their medicines adequately, and we can prevent these deaths. If you look at the figure on the right side, you can here see both the 5 steps approach to asthma treatment from GINA, which I advise people to review, but also something that is new in GINA to 2020 is how to start treatment. And they advise exactly when to start when you look at the different sets of symptoms and severity of symptoms and frequency of symptoms, if you start on step 1, 2, 3, or 4. So this is a very good way to review our asthma treatment. It has been updated in between 2019 and 20. There's new recommendation for step 1. So at step 1, you should only use, you should not use short-acting beta agonists alone. You should either combine them with an inhaled steroid or start with as-needed low-dose ICS formoterol. And this has changed quite dramatically what used to be done in the past recommendations for asthma treatment. And moving on, what if spirometry is not available? And this is something that has been subject of debate. As much as possible, we should have evidence that there is reversible obstruction if you want to diagnose asthma. But in some cases, it's not immediately available. And when we do a spirometry, the spirometry might be normal. So it's important to try to show some evidence that there was a reversible obstruction. And that can be done with peak flow meters that are done in practice. It can be aided by the use of validated questionnaires, and that some of these validated questionnaires can help you to diagnose asthma together with the peak flow meter. For the use of peak flow meter, there are different diagnostic criteria than there are for spirometry. I usually prefer to use this daily PEF variation over 10%. Nowadays, what is recommended by GINA is to have an excessive diurnal variability for 1-2 weeks, twice daily PEF monitoring. But it can also be done that once you have a suspicion of asthma, you record the FEV1 or the PEF, and with the peak flow meter, you can only record the PEF. And after 4 weeks of inhaled steroids, you record again, and it shows that it has improved, and that can help you with diagnosis.
A lot of GPs don't keep a peak flow meter in their practice across the world, and even if they do, I have seen many of them don't use it. So is there any message that you can give, Jaime, on peak flow meter usage in clinical practice to many?
Sure, yes, sure. The peak flow meter is a very useful tool. As I've said before, if possible, it would be better to have immediately available spirometry.
Right.
If practitioners don't even have a peak flow meter, it's very unlikely that they don't have immediate access to spirometry. So at least you should purchase a peak flow meter which is not that expensive, with disposable mouthpieces.
Yes.
And then you can do the peak flow meter immediately. So you have a patient coming into your practice with wheezing, shortness of breath, and you measure the peak flow meter, you give them a bronchodilator, short-acting bronchodilator, and after 20 minutes you check again, and if this shows that there has been an improvement according to the standards I have just mentioned, then it is very likely that it is asthma. If the patient is not on an acute stage but is mentioning symptoms, and you measure the path in your practice, and you give them a course of inhaled steroids for 4 weeks, and you measure it again after 4 weeks, and it shows an improvement of 10%, then it is, I think it's 20%, sorry, it shows that probably it was asthma. It is very likely that it was asthma. So even in cases where you don't have spirometry available, a combination of standardized questionnaires and use of peak flow meters can be extremely helpful in making a record of probable asthma. And this probable asthma means a lot, because you have a higher probability than if you just diagnose it on clinical criteria alone.
Yeah,
so I think it's advisable to use them.
Absolutely, I think so as well.
The peak flow meter and the spirometer, there is what they call the mini spirometer, which measure FEV1 and FEV6.
Yeah.
And the comparison between FEV1 and FEV6, FEV6 is a proxy to FVC. So by using that in clinic, which you don't require such an expensive and time-consuming test as a spirometer, you can have a better chance of diagnosis when you compare it with a good clinical tool.
Do you see more of those FEV6 devices being used in the future, Jaime, in primary care?
Well, I think that nowadays the next stage is not the separate ones, but you use it on your cell phone.
Sure.
Now there's quite good devices that you just have a small piece that you attach to your phone, and with disposable mouthpieces. That's before COVID. Now with COVID we can do that. But you could use it with your small program in your phone, and you have that also available. But there is a use for that because it's quickly done in practice. Not so much, I would say, for diagnosis, but as I said, for excluding diagnosis.
Sure.
But eventually for follow-up and monitoring. That is more useful than for diagnosis.
Sure.
All this technology is coming, right? As technology is coming, things are getting smaller and less expensive and more available to all of us around the world. At the end of the day, we want to have a firm diagnosis, because with a firm diagnosis, we can decide our therapy appropriately. That's what it comes down to. And certain therapy is going to be across the board for both diseases. We're vaccinating, we're preventing smoking, we're exercising. That's important for everybody. When we talk about pharmacotherapy, there's some pretty important pearls here and some basic differences that are going to be the difference. And the difference number one, of course, is that for asthma, we do not want to give just a bronchodilator. And we've talked about Gina saying now that inhaled steroids at every step, but also we've learned that long-acting beta agonists in asthma as monotherapy convey a risk of mortality. And that was something found in the salmeterol monotherapy asthma relief trial, where young people were given salmeterol when LABAs were first coming around without inhaled steroids, and about 20 young Afro-Americans died. So LABA monotherapy is bad for asthma. Similarly, inhaled steroids, as we talked about earlier, does not treat COPD. They don't treat mild COPD at all, and therefore there's no value in treating it. So isolated ICS shouldn't be used in COPD. That doesn't mean steroids shouldn't be used in COPD in the appropriate patient for exacerbation reduction and so on. It can be quite important. So overall, we want to make sure our treatment matches the condition. And there's some overlap because we use both drugs for both conditions. But if we do this appropriately, then we're giving the right drug to the right person at the right time. And isn't that what we're trying to do for everybody? Okay, let's move on to case 2. So this is a young lady, a patient of mine. She is a nurse. I'll give you a little background. She had a history of scoliosis with a rod. And she works very hard. She's a bright lady. And she had episodes of recurrent wheeze. And she worked in the dialysis unit where there's lots of chemicals, and she was finally diagnosed with occupational asthma. Now, Jaime talked about peak flow meters earlier. You start with peak flow meters for occupational asthma. You do at work and at home, And then you do methacholine both while working and then again at a time off work to actually make the firm diagnosis. It's a complicated diagnosis, and there's a lot of medical legal implications for this in terms of employment and workers' compensation and so on. But anyway, went through all this, and she actually had to change her job and work in a different setting, and that settled down her asthma. But things didn't settle from there, because then she was getting episodes of recurrent sinusitis, and I would do x-rays occasionally with these sinusitis, and lo and behold, there was a full-blown sinus full of fluid each time. And we did spirometry on her to see how much of this was related to her asthma. And she had a little bit of obstruction, a little bit of restriction, and she had about 10% reversibility. Remember at the beginning we said reversibility was at least 12% and preferably a little higher. So it was borderline. So she was seen, people get bounced around in the system. She ended up seeing a respirologist, not sent by me, sent by one of her other doctors. And he put her on inhaled steroids and a LABA combination because that reversibility to her, to the doctor, felt like it was asthma. But she did not get better, which of course is a pretty good marker that something might be amiss in terms of what's going on if she's not getting better with ICS LABA and she has asthma. Of course, the first step is to make sure that she's taking it and she's taking it correctly. So when we talk about the reasons for poor asthma control, you got to go through those basics. The first step, again, is making the diagnosis correctly. So again, in this lady, I don't think we've proved the diagnosis with her because her spirometry was not diagnostic 100%. It was suggestive. So is she taking her medication? I can tell you this lady was very adherent. She was very motivated to get better. Was she taking it correctly? Was she using the inhaler properly? And she was. So we have to think, well, could there be something else that's going on to affecting her asthma if it's asthma? And this is a situation where you could have rhinitis or GERD that can worsen asthma. Of course, obesity causes phenotype changes in asthma, and psychological overlay can affect asthma as well. Again, if she has asthma, just going through it, if she has the asthma process, does she have a trigger that's not been addressed, like smoking and pets and house dust mite and so on? And then if we've chosen the right drugs, and Jaime's already alluded to earlier, stepping up asthma to a biologic in people with severe asthma. So this is an article that we wrote in 2008 that looked at these steps, and I think they're still quite valid today. If we go on to the next slide, Jaime's going to talk about an IPCRG tool that we created as well along this line.
Yes, this was an initiative from the International Pharmacotherapy Group, with which we developed actually a desktop helper, improving the care of adults with difficult to manage asthma. And it has been translated into many languages, so it's not only available in English. And this has a rather complicated algorithm. I'm not going through all the details, but it investigates different steps. So it has been actually simplified by the use of simples. And this is a very easy approach, this acronym that you can remember quite well. So you look about smoking. Is the patient smoking? Is the inhaler technique correct? Is the patient doing it as it should be done? Is it actually doing it? And so about monitoring, and also about pharmacotherapy. Should you go up or down the treatment? Are the patient having the adequate treatment for the asthma step? How is it lifestyle? Is patient exposed to allergens? Is the patient exposed to fumes or smoking? What about education? Does the patient understand the condition? Does the patient understand what asthma means and what it has to be done? And also what kind of support, and mostly for children who have somebody to care for them, or even elderly, what kind of support they have, support in their job in terms of eviction, the support in their environment. So these are quite an interesting approach that people can have for difficult to manage asthma, before you just say, well, the patient is not controlled, let's go one step up on treatment or refer the patient. Maybe there's a lot you have to do.
Absolutely. So, this is a lovely tool that we created to sort of assist clinicians before having to refer everybody out. I think asthma is a primary care condition that can be treated by primary care practitioners before referring out for the most part. But this case really highlighted something else, and this highlighted that something that looks like asthma may not be asthma, and what might it be? And so moving on, just to show you about this case, and you can see that this young woman's X-rays and CT scans show, well, on the right you can see just the X-ray doesn't look very clean. It's just a little dirty there in that upper lobe. And if you look at the CT scan, you can see those little sacs, and those little sacs are little sacs of bronchi that we call our bronchiectatic sacs. If we look at the next slide, it looks a little bit bigger, and you can see they're larger sacs there. That's not normal. Those are little sacs that contain fluid and often infection. So that's called bronchiectasis. So now we have a different situation. Remember our nurse who had this cough and wheeze, and we look at her CT of her sinuses, and she's also got, and you can see there on the right, her left ethmoid and maxillary sinus is all filled up with fluid. She's got sinusitis. So she has bronchiectasis and sinusitis. So is this asthma anymore? Now we're rethinking this because it seems to have an infectious component and there's something else going on. Is there a structural component? So I think it's reasonable to consider in someone like this some more detailed investigations. CBC is useful for both a neutrophil count and an eosinophil count. The eosinophil count helps us decide on steroid treatment. We've talked about alpha-1 levels earlier. A protein immunoelectrophoresis for someone like this would be important because maybe this is someone who's got an immune deficiency and is therefore unable to prevent these infections and able to treat them and therefore leading to bad infections. I'll mention pheno here overall, not for this case particularly, although I did use it in this case. Pheno, or fractionated cell nitric oxide, is a small handheld device now that's available in many parts of the world, where you breathe into it and it gives you a surrogate measurement of eosinophilic inflammation. It's very useful for assessing adherence, and it's very useful, as it's going to happen in this case I'm going to show you very shortly. So moving on to this case.
Alan, just on pheno, just a question on pheno.
Yeah.
Simple to use. I don't know how the cost compares to a spirometer in Canada, but I just wanted to know what would you say is the utility in primary care from your viewpoint?
So it is available. It's available in most countries in the world. There's a number of different companies now that make it as well, which is giving us some choice, which is great.
Right.
It is easy to do in primary care. It's a simple airway maneuver. It's much less difficult to do of an airway maneuver than spirometry is.
Right.
Cost is an issue. Right now, it's not compensated in Canada as a procedure. So when I had my own machine, I basically had to pay for it myself, and I had to charge patients, which I couldn't be bothered. So it just basically cost me a lot of money, but it did give me some interesting information. What can it give you? Yeah. It can help validate your diagnosis. If you have someone who you think has asthma, and they're very symptomatic, and their pheno is low, it probably isn't asthma if they haven't been treated. You can use it to assess adherence, because if they're taking their medication and their pheno is still high, then either they're not adherent or they have severe asthma. And we haven't talked a lot about that, but it is a biomarker for one of our severe asthma therapies called dupilumab. It's a very excellent biomarker for that. And then lastly, it does help to monitor therapy. So if you give someone a treatment and their pheno is falling, you know you're going in the right direction. If it's not falling, then again, why is that? And do they have some other kind of inflammatory condition, or again, are they non-adherent? So there's a few ways of using it. I'm going to come back to how I used it in this particular case as well. So let me just go on with this case, because she had bronchiectasis and sinusitis. She had a normal protein immunoelectrophoresis, so she did not have an immune deficiency. And she ended up having to have her sinuses drained. And while they were there, I asked the ENT doctor to do a biopsy of the actual sinuses as well, because I was suspecting what she had. And it did show ciliary akinesia. So ciliary akinesia is a very unusual situation where you don't have enough cilia. And when you don't have cilia, then you get developmental abnormalities. So what I didn't tell you about her, of course, I did tell you about her scoliosis, and I think maybe that's related to that, but she was also infertile. So we know that cilia is important in fertility and moving the eggs along the fallopian tube. And that fooled me because she had children. And then I realized actually that she actually had adopted her children, which I hadn't realized initially because I started looking after her when she was a little bit older. So that biopsy is there. Now, that's nothing we can really do about treating this. This becomes a physical thing. So what I did do for her was I weaned her off inhaled steroids very carefully, monitoring her pheno the entire time. And she still had symptoms, and she was off her inhaled steroids and her pheno was still low. I was quite comfortable at this point saying that she did not have asthma because her pheno was negative and she still had symptoms. So by the way, she had bronchiectasis. So one of the things I do is work up for either tuberculosis or non-tuberculous mycobacteria. Obviously, depending where in the world you are, it's going to be different etiologies. In developing countries, again, tuberculosis where you are, I know is a much bigger problem than it is in North America and in Europe. Those were negative for her. The treatment for her is to bronchodilate a little bit to help her clear her secretions, saline lavages for her nose, and airway clearance devices to help her get her mucus up. We'll move on to the next slide. I want to just describe airway clearance devices. There's a number of them around. The old ones are called the Flutter and the Acapella. The newer one by Trudell is called the Aerobica device, which I think is pretty fancy. But the concept on the bottom is, you can see that on the left is a plug of mucus. And what happens is if we can get air in behind that plug of mucus, we can actually get it to be expelled. So this oscillating positive pressure device, where you breathe in through this machine and it flutters a breath through, causes this flutter wave to get in behind that mucus plug into the airway, even if it's a distended airway, and then it bounces back and helps you clear secretions. So with this oscillating positive pressure device, it's actually wonderful to help clear secretions. And all you basically have to do is you have to sit there at rest at tidal volume, just breathe in and out through the device for 15-20 minutes a couple times a day. And it's wonderfully effective for people who have a lot of mucus, like cystic fibrosis, bronchiectasis, and chronic bronchitic COPDers that have a lot of mucus as well. So in this lady, steroids was not the right answer. We talked about that being an issue before, using the right medicine for the right person. For her, it was a beta bronchodilator and airway clearance devices. So in summary, what this case really shows is that many things can look like asthma. If we make a firm diagnosis, we're less likely to get caught out with the wrong problem. Sean Aaron did a lovely article about this in terms of people that didn't have asthma but were called asthma in Canada, went through an entire process where they had spirometry, then methacholine, they reduced off their medications, and a good number of people did not have asthma at all. And you could predict who didn't have asthma based on the fact they didn't have spirometry done prior to the initiation of therapy. What's important, though, is a number of them had very severe diagnosis and things that, being not making the right diagnosis, had a risk of morbidity and mortality for them. So again, very simply, though, I understand we're going to trial treatment because that's what we do. We don't have these diagnostic tests available easily, and I understand that. But please, if you've given a treatment and it hasn't worked the way you expect it to work, make sure you follow up with your patients and say, wait a minute, this isn't working. Why? Is it something different?
Fascinating case. Jamie, please.
So here we have an 18-year-old girl. She's a patient on nebulized budesonide and formoterol. Started using this as a child and liked it better than dry powder inhalers. This is quite a common case. Not everybody likes dry powder inhalers, and many people like nebulizers. Why so?
But James, why this fascination for nebulizers in children? I mean, we see it in some parts of the world and not so many. Is there any reason? We know that the inhalers work as well. Do you have a thought why people like to put them?
I have a thought, and there's been some research on that. It has to do a lot with the fact that people have seen that when they have severe, when they have asthma exacerbations and they go to the ER or they go to their clinic, they very often were put on nebulizers because it was thought to be an easy way and quick way of delivering the treatment. And people thought always, and they associate worsening of symptoms with use of nebulizers, so that must be a very good thing. When nebulizers start getting cheaper and more available, people started buying them to have at home, and actually it was encouraged. I'll just give you an example. In my country, in the past, you could have a nebulizer at home for no cost at all from the National Health Service, and you have to pay for your spacer. I've been fighting for 20 years until finally the nebulizers have been recommended not to be used in practice unless in certain conditions that we'll see further in this case. And then spacers got paid by the National Health Service, not fully, but at least there's a co-payment from the National Health Service, and they became much more affordable. So just by a small, simple measure, people got the idea that nebulizers were the best thing.
It's like one pediatrician told us in Mumbai that it's very simple to use. And I said, how can you call it simple when it takes much more time to use?
Yes, exactly.
And she said, fill it, shut it, and forget it, she told me. So I said, okay.
So the question is, are nebulizers really better? And so in this paper from the Clinical Pediatrics from 2008,
right,
the authors conclude that despite the evidence that the PMDIs with or without spacers may be as effective as delivering medication for acute asthma, nebulizers continue to be popular with both practitioners and patients, mainly because they require minimal patient cooperation. And this is another thing which I failed to mention, is that it is also some kind of idea that, well, this device works for me. I don't have to make any effort, so it must be much better, which is actually not necessarily so. Does COVID change that? Alan.
So nebulizers have this great attraction because you just slap it on, as you say, Sujit, and you don't have to think about it. You don't have to think about your inhaler technique.
Sure.
There's also this mystique about having this mist coming out there that must be magically better, and technology is always exciting for people to have something that looks like this is so much more high tech.
Sure.
But we do know the evidence is clear that they're not any better. We have actually changed with our first SARS episode. We started changing in North America. We no longer use nebulizers for acute asthma. We use chambers and MDIs because of just that risk of infection translation, which then leads to COVID. And of course, Gina, amongst other organizations, have given some guidance about COVID and asthma. The next slide talks about overall the principles here, that actually asthmatics are not at higher risk of developing COVID and not at higher risk of developing severe COVID unless they are uncontrolled. So the clear message is they should take their asthma medications and stay in control, especially inhaled steroids. More recently, there's a couple of trials using budesonide called the STOIC and the Principle trial that have actually shown that using budesonide, 800 micrograms twice a day for people with early COVID, as long as it's symptomatic, can actually decrease hospitalizations and endpoints. So inhaled steroids may actually prevent the attachment of the virus to the ACE receptor in the lung. So this is very exciting times in terms of trying to find something to do about it. But just go back for a second, Jaime, I'm sorry, that we also want to talk about nebulizers being something that they shouldn't use because of that aerosol generating procedure. And of course, this is a really good time to reinforce adherence, because people are very afraid, as they should be, and certainly right around the world now we're having our third wave of COVID. They should be afraid of this, and therefore having an action plan to deal with their asthma so they don't have to go see a clinician, just stepping up their therapy if their asthma symptoms increase in the absence of COVID symptoms. So moving on to the next one.
So Alan, do you see, sorry to interrupt you, Alan, but do you see a sea change in asthma practice because of COVID in the future as well?
Well, excellent question. The current change is we're not doing spirometry routinely. That's big.
Right.
Nebulizers are now being taken off as a routine therapy. Most countries don't use a lot of outpatient nebulizers, but United States, our neighbor to the south, partly because of economic reasons, as Jaime had said, they actually fund nebulizers different than other medications.
Right.
People have handheld nebulizers. They walk around with a little handheld nebulizer. Well, this is no longer going to be okay in the COVID world. Right. And I think nebulizers, acute treatment, we've already taken out of our institutions for the most part because after the first SARS epidemic. Right. So I think now we're not using nebulizers as much. So that's certainly in the acute management. The home management is something I personally have not been using nebulizers like Jaime for many, many years, because again, as you said, why would you want to sit there for a half an hour treatment when you can give a treatment for just 30 seconds and get the same benefit? It doesn't make much sense.
Sure.
So just to finish the COVID, we're talking about vaccinations. Please don't forget your vaccinations for other conditions. Don't forget your pneumococcal vaccinations, your influenza vaccinations. We fortunately had a very good flu season this year because everyone was wearing masks, it's less transmitted. But doesn't mean influenza is not important. And obviously the COVID vaccines could be an entire conversation that we don't have time for today, but there's 4 or 5 different vaccines coming and more coming. And obviously we're going to pick the right vaccine for the right person. In terms of the asthma and the airway thing, just remember, of course, that the Pfizer vaccine does have a risk of anaphylaxis. So please be careful in people with a history of anaphylaxis if you're going to be giving the Pfizer vaccine to that particular group. So otherwise, we want people to get vaccinated. And what you're going to have is people will come in and ask you, is it okay for me to get a vaccine because I have asthma? And of course, our answer is yes, please, yes. Importantly, yes. All of you get vaccinated, because if we don't all get vaccinated, we're going to miss the opportunity of herd immunity. And the cost of all that is, of course, going to be new vaccine mutations, which we're already going through. We already have to do a flu shot every year because of mutations. Hopefully, we can get on top of this with COVID and get everybody vaccinated so the virus doesn't learn to mutate and get outside of our control. Anyhow, moving on to the next slide.
So here are the guiding principles for the use of nebulized LAMA in patients with COPD and for asthma. So there are guidelines. So on the left part of the slide, you have the ones for COPD, and on the right for asthma. So when there are some cognitive and physical abilities that hinder the use of spacers or chambers, identification of the frequent exacerbator phenotype, and it's the same for asthma. For example, the need to improve utilization of long-acting bronchodilators, the personalization of therapy to include appropriate device selection based on patient's needs, and it's the same for asthma. And assessment of short-acting bronchodilator use and recent symptom trajectory, and the same for exacerbations in asthma. So there are quite general guiding principles that actually in some countries there are guidelines where recommended to use nebulizers and not to use nebulizers. So
important just to add to Jaime that there are some people that need nebulizers or need a different mechanism than a regular dry powder and MDI. And if they just physically can't use one, if they have a neuromuscular problem, they have a neurologic problem, they have a bad Bell's palsy and can't seal for a dry powder, but there are physical reasons and cognitive issues where you just can't use it. And then a nebulizer is reasonable, although I'm going to give you another alternative for that in just a moment.
Again, in the journal Pediatrics, in which the conclusion from this study on inhalation therapy in asthma is that for the same age groups, there are equivalent percentages of total lung deposition by either a nebulizer or a PMDI with a chamber or spacer. However, total dose of salbutamol and delivery rate per minute were higher with the nebulizer in this study, which it's just a finding, but actually doesn't advocate for the use of nebulizers. So think twice about nebulizers for asthma attacks. And there's another paper stressing that MDIs with spacer are as effective as nebulizers for delivering beta agonists and less likely to cause adverse effects. So what to do, Alan?
So remember when you use a nebulizer as well, you're wasting a lot of medication because most of it goes into the air. Also remember that if you nebulize anticholinergics and it gets into the eye, if you have a narrow angle, it can precipitate acute angle closure glaucoma. There's been many cases of that in the literature. So nebulizers are not the panacea. In fact, they may do more harm than good. And I think that's what Jaime has really emphasized here, is that it's not the right answer for most people. That being said, what do we do for this young lady who says, I don't want to use a dry powder. I like my nebulizer. I don't want to change. So we have choices. We can keep giving her a nebulizer. She can keep using her nebulizer in her home, which of course, if she does get COVID, puts her family at risk. I think that's not the greatest idea. We can change to dry powder and ignore what she said. Well, that's a terrible mistake, because if she is not happy with the device, she's not going to use it. Her outcomes will be worse. We could just change to an MDI and see if she's comfortable with using an MDI, because some people like the drive of the MDI and the fact that it's pushed out at you and the spray is there. And the new HFAs are a little less a hard spray than the old CFCs. Or we could actually move on to a spacer and put the MDI into a spacer. And that gets rid of some of those timing and issues that require there, and you can get rid of some of the cognitive issues. So if we just go on to the next slides, we do recognize that the use of MDIs are fraught with error. And there's many, many different trials that have shown that using an MDI is not done properly, not coordinated properly, and the medications don't get into the lung. In order to use an MDI properly, you have to coordinate the spray with a slow inhalation, gradual inhalation, to get the flow beyond the back of the throat and to get it down to the lower lungs. And then, of course, you have to make sure to hold it afterwards. So you've all seen patients who breathe it in too fast. You've all seen patients who spray and don't wait between doses. There's so many things that people do wrong, and that's why we actually have to watch people use their medication. But if we use a spacer in the next slide, you can see that it's really going to optimize the therapy. By putting a spacer on, we get rid of some of those large particles which otherwise would have just hit the back of the airway, and the smaller particles are better able to be inhaled down to the lower part of the lung where they actually work. We don't want particles in the upper airway. That's what just causes thrush and dysphonia and cough. We want particles into the lower airway where they're going to actually be active. And by using a spacer device, we can actually mediate the medication getting down lower. And because you're just spraying into the device and then breathing at your own sort of rate for the most part, then you can actually not have to time it quite as well. Clearly, if you time it, it works a bit better. But even for young children, the way we use a spacer with a mask, and then just have the child breathe at the regular tidal volume, 6 to 8 breaths, they're going to get the medication from the spacer. So I think for the most part, if we use a spacer with an MDI, we're going to have much better delivery. And quite frankly, I think for anyone who's using an MDI steroid, a spacer is almost key in terms of getting proper delivery. So if we look at this next slide, we can talk about, here's some evidence that says, well, if you use an MDI without a spacer and you delay that inhalation by just a half a second. So normally you should start your breath as you press on the device. But if you delay for just a half a second, your oropharyngeal deposition goes up to 60%, versus 10%. Your lung deposition goes down significantly. So what's happening here by using the spacers, we're getting the medication into the lungs, even if you do have that delay of delivering the medication properly, inhaling at the right time. So the spacer allows for those errors of technique and so on. Next slide. So once again, just saying, looking at this a little bit differently, here's a situation again where there's a couple of drug names there, but it doesn't matter which medication we're talking about because I showed you this is suspension or solution because some of the inhaled steroids come in different delivery systems. But you can see that if you use a valve holding chamber, your amount of oropharyngeal deposition is much less. And I'm sure like me, you have patients that develop thrush and have irritation in their throat because of the steroids, have trouble singing and so on. Using a chamber will make a great difference to that. So if we move on to the next slide, I think that I'd like to point out the fact that even spacers can be used incorrectly. And a colleague of mine gave me this slide many years ago, and I always show it because you can see what's happened. This person has stuck the inhaler into the spacer with the cap on. And then if you spray into the spacer with the cap on, guess what? You're not going to get any medication. And then to add insult to injury, when she pulled it out, she left the old caps in there. So that's going to affect the effectiveness of the spacer. So once again, the point this makes to me is that we actually have to see our patients use their inhalers. We have to watch them. And I know this is a virtual world now with COVID. Often we're doing things virtually, but we have the ability and the technology to watch people use the devices through a Zoom video or a FaceTime or something like that. So actually watching people to do this. So what actually happened with this young lady, next slide, is she did not want to use a dry powder. So again, don't bang your head against the wall on this because she's not going to use it and you're going to have bad outcomes. We switched her to an ICS LABA MDI with a valve holding chamber. And she was actually quite happy with this because she didn't have to time it so much. Okay. Again, you can use a chamber with or without a mask. The advantage of using a mask is sometimes you inhale a little bit through the nose. So if you have rhinitis, you may get some benefit that way. Otherwise, most people could just manage with the chamber without the mask. It's a little less costly. And frankly, she started taking it pretty well just once a day. And this was a twice a day ICS LABA. So what that means to me is she's probably getting enough ICS now that her asthma is well enough controlled that she may not even need the lab anymore. And we might even be able to step her down to an ICS, which highlights the factor that asthma is a condition that we continue to follow over time. And we step up therapy, which I think we do when we have lack of control. We've talked about that. But we can also step down therapy when people are doing well, because as Jaime said right at the beginning, we want to use the lowest amount of medication to keep someone controlled to prevent the side effects of the medication.
Two things here, Alan. One is you talked about teaching patients how to use an inhaler online, virtually. Do you see this as a significant uncoupling of time in your clinic, that someone could just be present virtually to teach every device for your patients?
So we actually have right now very much a virtual world. We're seeing most of our patients virtually.
Right.
Our government was kind enough to compensate us for this. And because patients are afraid to come to the office, and quite frankly, we're a little bit afraid of them because bringing us COVID, so we're doing this virtually. So this is not a skill you can do on the telephone. This is a skill that has to be seen, and we have the technology to do that. So it's certainly something that can be done. It can be done by your staff member, it can be done by yourself.
Sure.
There's also a video available on YouTube and things like that for every single device. So you can actually direct our patients to actually watch videos as well to try to ensure. But I actually like to personally see or have one of my staff who I trust personally watch someone use their device to make sure they're using it correctly. Because again, if the medication doesn't get to the lung, it's not going to work. And that's a pretty good reason why people don't do well.
And another thing we find is that when the patient is doing well, nobody's in a hurry to step down therapy. Any message to primary care physicians when they should start stepping down?
Yeah, so I think I personalize that question to say, do any of you in the audience like taking medication? Would any of you like to take less medication than you're taking now? Right. And I think if you say no to that, you're actually fooling yourself.
Sure.
So with that in mind, I think we also want to minimize the amount of medication our patients are taking, if possible. Our goal is control. So we want to have enough medication to keep the asthma well controlled, to prevent exacerbations, to prevent quality of life effects. But that being said, if we can do it with less medications, we should. So there is recommendations for this, decreasing the inhaled steroid by 25 to 50% every 3 months in a stable situation. Please don't do it right now during COVID, because the last thing you want to do is have people getting symptomatic during COVID, because then you're not sure if it's COVID or not, and that brings up a whole other differential diagnosis. Don't do it if you're pregnant, because if you're pregnant, you don't want to step down and get an exacerbation. It's bad for the mother and the baby. And don't do it if you're about to travel. Not that anybody's traveling now, but don't do it if you're about to travel, because it may be difficult to get healthcare when you're far away from home. But other than that, in a stable situation, no exacerbations, really good control, I think it's reasonable to cut down your steroid dose by 25 to 50%. And when you get down to a bit of a lower dose ICS LABA, potentially, as in this case, potentially stepping off the LABA because it's not necessary anymore.
Sure.
To that, if I may add to that, I think it is a very good point that Alan just said. Furthermore, from the patient point of view, and if you consider the patient point of view, very often patients will discontinue or even reduce the number of times they do the inhaled steroid, and not always tell the physician. So, knowing that the right approach is to tell the patient that they should use the inhaler in order to control symptoms, and if symptoms are under control, it means that they don't need to use it so often. We can actually validate the need to step down and tell this to the patient. We are actually, rather than the patient not doing it and hiding it from us, we are actually validating something that is good practice, good clinical practice, which is to step up and down according to the variability of asthma symptoms along the ear or along the mouth. As we know, asthma is a very variable condition with different symptoms every day and every month. So we can step down and step up according to the needs of the patient, and this needs to be done in a more proper way by interacting with the patient. And going back to the question of teaching how to use inhaler, I think it's something that is absolutely fundamental, that in every country, in every region, we have active teaching of health professionals on how to use an update, because even those who are not interested in respiratory conditions like we are, very often family physicians, general practitioners, they will forget how to use the proper way of using inhalers, and actually also they will not be familiar with new inhalers that are being developed and are in the market. So it's very important that we have frequent updates, and this teaching of the health professionals that will then be teaching patients should be actively with hands-on. And now, as Alan said, we are having a situation in which we have to teach online, so we have to be innovative and have new ways of teaching how to use inhalers, not face-to-face, but using distance teaching and remote teaching, as well as we are going to do remote consultation for our patients.
Oh. And Jaime, speaking of COVID, which Alan brought up, what is your thought on stoic and principle? I mean, these studies have been hitting the media headlines across the world now. What's your thought? Is it asthma that's protecting them, or would you think it's the inhaled steroid that is protecting patients? And what's your recommendation for COVID treatment when it comes to that?
I have an answer on that, but my recommendation for COVID for asthma patients during the pandemic is that they should keep on having their inhaled steroids.
Sure.
And if those who need oral steroids, the few ones who need oral steroids, should not withdraw. It's important to have asthma under control. Whatever treatment they will get for their COVID, if they get infected, it will be worse if their asthma is less controlled.
Correct.
And this is a very important message for all. Don't withdraw treatment. Advise your patients to keep on good control of their asthma rather than being afraid of getting COVID, because there is no proof that patients on asthma treatment get more chances of being infected than others. And actually, you are more protected if you are well under control.
And what about the non-asthmatic prescribing them inhaled budesonide with COVID?
We have to be very careful about that. There's a lot of innovative ideas coming in which have not been fully validated by research. So we have to be very careful about that.
Sure.
There is some scientific thought behind this.
Yes.
When we go back to the Middle Eastern respiratory syndrome a number of years ago,
yes,
it was discovered that inhaled steroids actually prevent the adhesion of the virus to the receptors in the lung. So that was part of the reason behind where they thought about this. So asthma is one thing. If you have asthma, the bottom line is treat your asthma aggressively and keep control to prevent getting bad COVID, getting severe COVID.
Right.
If you have asthma, you have no higher risk of getting COVID than anybody else. But if your asthma is uncontrolled, then you have a higher risk of getting severe COVID. You have severe airway obstruction, you have a higher risk of severe COVID. But for the non-asthmatic, the question is, what can we do for a non-asthmatic to prevent them developing severe COVID? And of course, the jury is still out on this. But we have, as you mentioned, 2 trials, the STOIC, which was a proof of concept, and the Principle, which is a bigger trial, where they took people over the age of 65 with COVID in the community, or over the age of 50 with a comorbidity, and they randomized them to 800 micrograms of budesonide twice a day or not. And they found that the group that had budesonide twice a day did have less incidence of severe COVID and hospitalizations. So these are patients with mild COVID. We're not talking about people with severe COVID in the hospital. We know that steroids decrease the inflammatory cytokine storm that occurs. But for prevention of a mild COVID patient from moving to a more severe situation, it's very intriguing to think whether or not budesonide can actually do that. There's also currently a study going on with ciclesonide, one in the United States and one in South Korea, doing the same thing.
Right.
So personally, as a patient that treats mild COVID, because I do that, I actually do start people on budesonide, 800 micrograms twice a day. The cost, I think, is very small in terms of risk.
Right.
Of course, they have to use it correctly, they have to inhale it properly, and they have to rinse their mouth afterwards and so on. And again, I don't think it's yet state-of-the-art treatment. But as I say with something that's either ahead of my time or wasting your time, I say that to my patients. I'm not sure which one, but I think the amount of harm is very negligible for this. So I personally have started routinely treating people who have risk with budesonide 800 micrograms twice a day to try to prevent them from moving on to more severe COVID. But that's a personal thing, and I think there's no guideline for that just yet.
And I'm very, very skeptical, sorry to say that, I'm really afraid that there is a rush to buy inhaled steroids from people in the community with no guidance at all, if because of this kind of headlines that hit the media, and then people are treating it without any guidance, and then we need the inhaled steroid for our patients. We might not have them. So, okay, I understand the point, but we need more guidance on that for sure.
Oh, that's interesting. Shortage of remdesivir, now shortage of budesonide. That's the last thing you want.
But this is not chloroquine. So we're not getting chloroquine issues because of a medicine that didn't work at all. It has real harm in terms of chloroquine. So I think the downside's a little less, but I certainly respect what Jaime said is an issue. We did have certainly an issue with inhaler availability early on in COVID. People were stockpiling their salbutamol. We didn't have enough. It was a real issue. So I think that is a concern. So yes, these are all things we have to think about. The question is what you can offer your patient to try to prevent them from getting more severe COVID. We only have so many things we can offer them once they get ill with it. I can tell you that personally, a colleague of mine is a family doctor in Edmonton who recently contracted COVID despite having one vaccine. A patient came to the office with it. He is an asthmatic, and again, our discussion was to make sure he increases his inhaled steroid to try to prevent him from having a bad outcome. And so far, he's feeling okay, and I'm grateful for that.
Sure. It's interesting how they did the Oxford study, because in the UK, there was no treatment being given for COVID at that time. When I spoke to Mona Bafadel, and she said that they were just treating them based on symptoms, and they offered an investigational drug. In India, we had a problem actually because so much was being thrown at the patient, which was not necessary, ivermectin, doxycycline, that it was hard to do a clinical trial actually in that setting. So it's interesting how different geographies look at this. And I get Jaime's point. You don't want to have an overkill on this without some better studies as well. I agree.
The problem with COVID is we don't have time. So we sort of have to jump in a little bit. So that's why all these things are being thrown about. I wanted to come back to your step down therapy and give one other comment about step down. I think Jamie alluded to this very nicely about the fact that stepping down is what patients often do themselves.
Right.
And because they do it themselves, they have to be comfortable to talk to us about that. And I think if we tell patients that our goal for them is to get them perfectly controlled with a minimal amount of therapy, and that we're going to work together with them to reduce their dose of medication to the optimal dose and the minimal dose, they feel less necessity to cut down on their own. Right. And the last comment on this is going to be, remember, asthma is a chronic disease. And it's quite clear that the recommendation is such that do not stop your inhaled steroids entirely. They should step down to a low dose, but not zero, because it's a chronic inflammatory eosinophilic pylori disease that requires long-term treatment. So just please remember that.
Absolutely, yeah. So we could come up to the summary now. I think that the important thing about this case is that it's important to make the correct diagnosis. It's also very important to reassess for optimal outcomes, and that drug delivery in obstructive airway disease is critically important to get it right. The way that the patient likes, the way that the patient does it properly, and the right dose and the right timing and the right frequency.
Thank you very much, Jaime. I think that really summarized that case very well. Now, I think Alan and Jaime, thank you so much. Fascinating cases, right? And a fascinating discussion also, Alan, on all the topics that we did. I think we covered 3 interesting cases and we discussed a lot today. Cannot thank both of you all enough for this. Thank you. So I would again like to thank our collaborators for this wonderful meeting we have had, the 6th episode in this series. And our collaborators, as I mentioned again, are the Sri Lankan College of Pulmonology, the Myanmar Thoracic Society, AAA and AOSR from Algeria, APPM and AFMAPath from Morocco, the Iranian Society of Pulmonology, SDNCT and Pneumonaut from the Dominican Republic, the Panama Pneumology Association, and the Yemeni Association for Respiratory Care. Thank you very much to all our collaborators.